Hello everyone, I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about ovarian tumors. So what we wanted to discuss today? The classification of ovarian tumor according to the FIGO and WHO, the histological types of ovarian tumor, epidemiology of ovarian tumor and the diagnosis, what are the methods of spread, and what are the staging and the screening methods, how to prevent and how to treat a case with ovarian carcinoma, treatment of recurrent ovarian cancer, the palliative and the end-of-life care, and lastly, the prognosis of ovarian cancer. As you see in this picture, this is a picture of ovarian serous adenocarcinoma. So before we start, we should know that the ovary is a very special organ, and the ovary embryologically derived from three sources: coelomic epithelium, adjacent mesoderm, and the primordial germ cell. The germ cells, as you see, migrating from the genital ridge to reaching here, the coelomic epithelium. This is the coelomic epithelium, as you see, and this is the germ cell, and this is the primordial follicles. Okay, so coming from coelomic epithelium and the mesoderm and the germ cell, that's why when tumor occur in the ovary can be of many histological types. So different types of ovarian tumor is present. Look to this picture, please. The main three types of ovarian tumor include the epithelial, which is the commonest one, coming from epithelium here, the coelomic epithelium, epithelial ovarian carcinoma, and germ cell ovarian cancer, as here from germ cell, or six-cord stromal tumor coming from the granulosa and Sertoli cell and the stroma cells, the fibroblast here in the stroma. So the three main types: epithelial, germ cell, and six-cord stromal tumor. This is the classification of the ovarian tumor according to the WHO. Surface epithelial, the commonest, like serous adenocarcinoma, that is this picture. Germ cell tumor, six-cord stromal tumor, mixed ovarian cell tumor, non-specific and unclassified tumor, and the secondaries, or what's called metastatic tumors to the ovary. Okay. Generally, ovarian tumor could be benign, borderline, and malignant, and this can be happening in the epithelial tumor, which is the commonest. This is the pictures of the histological types of ovarian tumor. The main three types: epithelial, serous adenocarcinoma here, germ cell tumor like this germinoma, six-cord stromal tumor as granulosa cell tumor, and secondary like Krukenberg tumor. So what about the WHO classification of the epithelial type? Epithelial type, as we said, it is the commonest one, including serous tumor, mucinous tumor, endometrioid tumor, clear cell, Brenner, undifferentiated, mixed epithelial tumor, and lastly the peritoneal carcinoma or serous carcinoma of undesignated site, where the ovaries and the fallopian tubes appear to be incidentally involved and not the primary origin. So, epithelial neoplasm is the most frequent, constitutes 90% of the ovarian tumor. The nomenclature for epithelial tumor based on the cellular origin. Epithelial tumors make up the bulk of the ovarian neoplasm and could be benign, borderline, and malignant. What is new in the epithelial ovarian cancer? The ovarian cancer is a complex disease and heterogeneous disease, with historically accepted hypotheses now being challenged. Why challenged? Because what we was recognizing as a primary origin or resulting from the ovary itself, like serous adenocarcinoma, is now changing to be coming from the fallopian tube, from serous intraepithelial carcinoma of the fallopian tube, and thus to the ovary, and many cases diagnosed as serous adenocarcinoma of ovarian origin was of fallopian tube origin. This is the new. So the fimbrial end may carry intraepithelial carcinoma or serous carcinoma and reach the ovary and start as if it is primary ovarian serous carcinoma. Specifically the high-grade serous carcinoma. Okay, that's why fallopian tube and the peritoneal cancers, as regard the emphago staging, they are amalgamated into a single system: fimbrial end or fallopian tube, ovary, and peritoneal cancers. What about the mucinous? Mucinous ovarian carcinoma, once deemed relatively common and now considered rare. The actual origin of this tumor remains controversial. Is it coming from other organs like GIT, like the appendix or whatever, and not the primary origin of the ovary, or come from another origin? So it is a controversy as regard its origin. Many of the ovarian mucinous tumors were in fact tumors of extra ovarian origin, and now it is estimated that the mucinous tumor accounts for 3 to 4% of ovarian cancer malignancies. The FIGO staging system was first published in 1973 and then revised in 1988 and 2014, and recently the classification paradigm has been modernized to include not only the tumor morphology but also the immunohistochemical and the molecular characterization to differentiate type 1 and the type 2 epithelial ovarian cancer. So what is type 1 and type 2? Type 1, as you see here, this is the ovarian cancer. This is the different types of ovarian cancer, and the commonest one, 90%, is the epithelial. You can divide the epithelial ovarian cancer recently into two types, type 1 and type 2. Type 1, like low-grade serous carcinoma, endometrioid carcinoma, clear cell carcinoma, mucinous carcinoma, malignant brain tumor, and seromucinous carcinoma. While type 2, including the high-grade serous carcinoma, the carcinosarcoma, and the undifferentiated carcinoma. Type 1 is less lethal, type 1, and better prognosis than type 2. Type 2 more aggressive, discovered late, and occur in advanced age, and first diagnosed in advanced stage. So it is dangerous and more dangerous than type 1. What about gene mutation? Genomic alteration, relatively common, KRS, BRF, BTN in type 1, while in type 2, linked to genetic mutation, TP53 mutations. Okay? Okay. Tumors in type 2, high grade. But tumor in type 1 usually present at an early stage and are low grade. What is the origin for each one? For type 1, endometriosis origin, giving endometrioid, clear cell, and seromucinous, or fallopian tube related like low-grade serous carcinoma. While the type 2 examples, high-grade serous carcinoma, carcinosarcoma, and undifferentiated carcinoma. Recently, in 2020, the WHO defined 5 main types of ovarian carcinoma and published in literature. The 5 types include the high-grade serous carcinoma, constitutes 70%, endometrioid carcinoma 10%, clear cell carcinoma 6 to 10%, low-grade serous carcinoma 5%, and the mucinous carcinoma 3 to 4%. And this is the table which show the 5 types reported by the WHO. This is the high-grade serous carcinoma. Site of origin is fallopian tube. Hereditary cancer syndrome, BRCA1 and 2, associated hereditary breast and ovarian cancer. This is in high-grade serous carcinoma. What about low-grade serous carcinoma? Coming from serous borderline tumor. This is a precursor, and the site of origin is the fallopian tube. What about endometrioid carcinoma, which constitute 10%? The origin from endometriosis and the precursor lesion, atypical endometriosis and the endometrioid borderline tumor, and the hereditary cancer syndrome here is Lynch syndrome. What about clear cell carcinoma, which constitutes 6 to 10%? The site of origin is endometriosis, the precursor lesion, atypical endometriosis, and the clear cell borderline tumor, also hereditary related to Lynch syndrome. What about the mucinous carcinoma? Constitutes 3 to 4%. The site of origin related to teratoma or unknown. There is controversy about the mucinous tumor actually. And the precursor lesion, the mucinous borderline tumor. Okay, epithelial tumor containing the most common serous cystadenocarcinoma. And this serous tumor divided into 2 main groups, low-grade serous tumor and the high-grade serous tumor. The low-grade serous tumor constitute 10% of all serous type, show minimal nuclear atypia and rare mitosis and less molecular abnormalities, occur at younger age, has a better prognosis than high-grade serous tumor, and high frequency of KRS and BRF mutations. On the other side, high-grade serous tumor constitutes 90% of all the serous subtype tumor, shows significant nuclear atypia and mitosis, with more copies of molecular abnormalities as seen by cytogenetic analysis. Tend to present at older age, more fatal prognosis, and 10-year mortality rate of 70%. There is a high frequency of B53 and the BRCA1 and 2 gene mutations. So, high-grade serous tumor, of course, of bad prognosis, and low-grade serous tumor is more better as regards the prognosis. This is the picture of 2 types of epithelial ovarian tumor, the serous tumor, serous cystadenocarcinoma, and the mucinous cystadenocarcinoma. What about the germ cell tumor? Germ cell tumor divided into 3 main categories. Germ cell tumor, monodermal teratoma, and somatic type tumors developed from a dermoid cyst, and lastly, germ cell 6-cord stromal tumors. This is the most recent classification. Germ cell tumors including dysgerminoma, which is the commonest malignant germ cell tumor, dysgerminoma, yolk sac tumor, embryonal carcinoma and polyembryoma, non-gestational choriocarcinoma, mature teratoma, immature teratoma, mixed germ cell tumor. The second big category is the monodermal teratoma and the somatic type tumor developed from dermoid cyst, include stroma ovary benign, stroma ovary malignant 1, carcinoid, stroma carcinoid, mucinous carcinoid, neuroectodermal tumor, species tumor, and the carcinoma, specifically squamous cell carcinoma and other carcinoma. The third big category is germ cell 6-cord stromal tumor, including gonadoblastoma and mixed germ cell cord stromal tumor and unclassified type. Really, ovarian germ cell tumor represent 20% of all ovarian neoplasm, where the malignant ovarian germ cell tumor comprise only 3%. Okay? And please notice the difference between, if we are talking about the incidence or prevalence of tumor, and we said for all ovarian neoplasm, it differs than the malignant ovarian neoplasm. Okay? So, ovarian germ cell tumor generally for all tumors, benign and malignant, constitute 20% of all ovarian neoplasm. But as regards the malignancy, it constitutes only 3%, the malignant ovarian germ cell tumor. What is the age common in germ cell tumor? The adolescent and the young children. And the most common benign tumor for germ cell tumor is a dermoid cyst or benign mature cystic teratoma, and the most common malignant one, as we mentioned before, is a dysgerminoma. So there is a variety of malignant ovarian germ cell tumor of histologic types like dysgerminoma, the undifferentiated one, immature teratoma, endodermal sinus tumor, carcinomas, polyembryoma, and the mixed malignant ovarian germ cell tumor. All these tumors deriving from primordial germ cell of the ovary. That's why we call it germ cell tumor. What is the difference between germ cell tumor and the epithelial ovarian tumor? Okay, and the epithelial ovarian cancer specifically. Incidence at an earlier age. Germ cell tumor occur at any earlier age. Yes. There is almost unilateral localization. 95% of cases unilateral. Their high rate of growth is another difference. Rare tendency to spread. Their good prognosis, and this good prognosis explained by the numerous diagnosis at an early stage and their high chemosensitivity. Many of the cases diagnosed as stage 1, so can be managed conservatively, and this is good because it affects the young age, as we mentioned before. This is the picture of dysgerminoma, how it looks. Look to the third big type of ovarian neoplasm, which is a sex-cord stromal tumor. We have recently this classification, which includes 3 main categories: pure sex-cord tumor, pure stromal tumor, and mixed sex-cord stromal tumor. In case of pure sex-cord tumors, we have the granulosa cells, which is the commonest in pure sex-cord tumor, and we have 2 types really of granulosa cell tumor: the adult type and juvenile type. The adult type occur in older age, while the juvenile type occur in younger age. The most common one is the adult type, 95%, while the juvenile type, 5% only. It is hormone-producing tumor, producing estrogen, and they can cause in young precocious puberty in childhood, and they can cause abnormal bleeding in a childbearing age, and can cause postmenopausal bleeding in postmenopausal women. The second type is a sertoli cell tumor producing androgen, and can cause virilization. The third type is sex-cord tumor with annular tubule, constitute 1.4% of all sex-cord stromal tumor. The second big category of sex-cord stromal tumor include pure stromal tumor. Fibroma constitutes 4% of all ovarian tumor, and this is the commonest tumor. Sarcoma constitute 0.5 to 1% of all ovarian tumor. Sclerosing stromal tumor, 5% of all sex-cord stromal tumor. Then the microcystic stromal tumor, Leydig cell tumor, and spheroid cell tumor, and the fibrosarcoma. The last big category is a mixed sex-cord stromal tumor, including certainly Leydig cell tumor, less than 0.5% of all ovarian tumor, and sex-cord stromal tumor, not otherwise specified. So what are the characters of this sex-cord tumor? They are infrequent and represent approximately 7% of the primary ovarian tumor, where the malignant sex-cord stromal tumor comprise only 2%. So 7% as regard in all ovarian neoplasm, and the 2% as regard the ovarian malignancy. Formed by diverse cell types that arise from the primitive six-chord or stromal cells. Although six-chord stromal tumor present in a broad age group, the majority tend to present as a low-grade disease that usually follow a non-aggressive clinical course in younger patients, and this allows us to do conservative surgery for such type of tumor. These tumors are engaged in ovarian steroid hormone production, androgen from sertoli cell, estrogen from granulosa cell, and the corticoid from steroid cell tumor, commonly associated with various hormone-mediated syndromes associated with hyperestrogenic condition or hyperandrogenic condition and virilization, as we mentioned before. This is the picture of six-chord stromal tumor in cut section. What about the secondaries of the ovary or metastatic tumor to the ovary? We can consider that the ovary is a frequent site for metastasis from genital and from non-gynecologic primary malignancies. These secondaries account for 5 to 10% of all ovarian tumor. GIT is the most common non-gynecologic primary tumor site that metastasizes to the ovary, followed by the breast. So GIT first, then the breast can give secondaries to the ovary. Why the ovary is considered a common site for metastasis? Actually, because it is an intraperitoneal structure not covered by peritoneum, and due to the rich blood and lymphatic vascular supply. Krockenberg tumor, very specific tumor related to metastasis in the ovary. It is a metastasis in the ovary coming from GIT, specifically the stomach, especially the stomach, which is more common than the colon. Then other parts of the GIT can send the metastasis to the ovary. This tumor characterized by mucin-rich segment ring adenocarcinoma, and the average age at diagnosis is 45. Often these tumors are bilateral, as in this picture. This is bilateral Krockenberg tumor. Over 80% are bilateral. This tumor named after Frederick Ernest Krockenberg. Of all the ovarian tumor diagnosed, Krockenberg tumor make about 1 to 2% of these tumors. So we can consider ovarian carcinoma is a heterogeneous disease consisting of a group of tumors with each different precursor lesion, pathogenesis, pattern of spread, response to chemotherapy, and the prognosis. What is the epidemiology of ovarian cancer? Ovarian cancer has lifetime risk 1.3% in the general population and accounts for only 1.3% of all new cancers. The second most common malignant gynecologic neoplasm after the breast in Western countries. Most malignant tumor, as we mentioned before, surface epithelial. It is the fifth leading cause of cancer-related disease in women. What about United States? United States alone, there are over 22,000 new cases of ovarian cancer each year, with 14,000 deaths related to ovarian cancer, and this is a large number. The CDC report that white women have the highest prevalence and the highest incidence per ethnicity after whites are Hispanics, Asian Pacific Islander, African Americans, and the American Indian Alaska Natives. The cancer mainly developed in older women. About half of the women who are diagnosed with ovarian cancer are 63 years or older, and the majority of the patients with epithelial ovarian cancer are diagnosed with advanced stage disease. Also, I can say that the Jewish Ashkenaz, the ovarian carcinoma is common in such people, and the possibility of occurrence 1 in 50, while in general population the possibility of occurrence of ovarian carcinoma 1 in 300 to 800. Imagine the difference. So Ashkenazi Jews has a very high risk to ovarian carcinoma. What are the risk factors for ovarian cancer? Genetic syndrome played a major role, accounting for about 10 to 12% of ovarian cancer. BRCA gene mutation involved in 10%, while Lynch syndrome involved in 2 to 3% of cases. BRCA1 and 2 gene mutation are the cause of hereditary breast and ovarian cancer syndrome, which affect 1 in 300 to 800 women. As we mentioned before, the prevalence may be higher than 1 in 50 among Ashkenazi Jews. In families with history of ovarian or breast cancer, BRCA mutation are responsible for about 90% of cases of ovarian cancer. The estimated lifetime risk of ovarian cancer is 40% in BRCA1 mutation, while it is 18% in BRCA2 mutation. So, BRCA1 is more dangerous. Other risk factors including postmenopausal hormone therapy, specifically if the woman take the hormone therapy for more than 5 years, this is carrier risk. Early menarche and late menopause, but with little evidence of their role. Obesity and weight gain is other risk factors. The role of diet, non-steroidal anti-inflammatory drugs, perineal talc exposure, and smoking are controversial. The effect of induction of ovulation in infertility cases is uncertain as a risk factor for ovarian cancer. What are the factors that reduce occurrence of ovarian carcinoma? It was found that taking COC or combined oral pills for years or more during the childbearing age reduces the risk of ovarian cancer by approximately 50% in BRCA mutation carriers. Also, dipomedroxyprogesterone use and salpingectomy and tubal ligation and the breastfeeding also reduce risk. It was found that multipara has a lower risk, late menarche and the early menopause also lowering the risk, but with less definitive evidence. Let us go to how to diagnose ovarian cancer from history, examination, and investigation. From history, by asking about the presenting symptoms. But unfortunately, early stage disease is usually asymptomatic, and usually ovarian cancer diagnosed late and in advanced stage, specifically in epithelial tumor. Late stage ovarian cancer often have symptoms, but these symptoms are also non-specific. That's why making the diagnosis to be more late. Like what? Like back pain, fatigue, abdominal bloating, pain, constipation, increased abdominal size, urinary symptoms for 3 months or more before diagnosis. And usually these patients don't ask help from gynecologists because they consider these symptoms related to GIT, so they go to internal medicine doctor, and many of the times are wasted before reaching diagnosis. Advanced disease may present with the symptoms and the signs of metastasis, such as bowel or urethral obstruction or shortness of breath in case of pleural effusion. Also, you should know the 6-item symptom index, like bloating, increased abdominal size, difficulty eating or feeling full quickly, and pelvic or abdominal pain. If a woman experiences these symptoms more than 12 times a month, and for duration less than a year, this 6-item index is considered positive. And they can correlate this 6-symptom index with CA125 and H and human epididymis protein 4 to increase the sensitivity and specificity for diagnosis. History of the presenting symptom may include paraneoplastic syndromes with neurological symptoms like subacute cerebellar degeneration, also unexplained spontaneous recurrent migratory venous thrombotic events, Rosier syndrome. An exception to the late presentation of ovarian cancer is, we mentioned before, sex-cord stromal tumors. Why? Because it is hormone producing. And we said that some of them producing estrogen, like granulosa cell tumor, and they can cause precocious puberty or abnormal uterine bleeding. And others, like sertoli cell tumor, can produce androgen and causing virilization. So the patient will ask for advice early, and this why this type of tumor is diagnosed early. Also, the aggressiveness of this tumor is less than that of epithelial ovarian tumor. So 70% of this tumor are diagnosed at stage 1. Assessment of the risk factors, including you should ask about the personal and the family history, any affection in any member of the family with ovarian cancer or breast cancer, or the patient herself, any previous cancer in the breast. Also, the age of the patient is important, and we know that the advanced age and the commonest tumor, which is epithelial, occur more in advanced age, above 60. Postmenopausal hormone therapy is a risk factor, so we should ask about any hormone therapy in postmenopausal women. Also, obesity and weight gain is considered another risk factor. Then, after history, then the general abdominal and the pelvic examination. General examination, we may see the cachexia, the pallor, jaundice, weakness, enlarged supraclavicular lymph nodes, or other evidence of metastasis, thrombophlebitis, pleural effusion, edema, or varicosities of the lower limb, especially if it is unilateral. During abdominal examination, as you see in the picture, you can palpate mass, and this mass may be solid or partially cystic. The mass may be on both sides, may be bilateral, may be fixed or of limited mobility due to infiltration to the surrounding, irregular in its contour. There is enlargement in the abdominal size. This can show pigmentation, as you see in the picture, and dilated veins, and may show umbilical mass like sister Mary Joseph nodules. This is sister Mary Joseph nodule. Here, she looks red at the umbilicus. Or any signs of complications. Also ascites. Pelvic examination, you can feel the mass, which is solid or partially cystic. Also, you can see nodules, feel nodules in the Douglas pouch over uterosacral ligaments. Also, you can see that the tumor is bilateral and it is of limited mobility and tender. Endometrioid and serous tumor have 10 to 20% risk of being bilateral. So what is the differential diagnosis? If we, during BV or bimanual examination, we felt pelvic or pelvic abdominal mass, we can classify the causes of pelvic mass into gynecologic and non-gynecologic. The gynecologic one, as we mentioned in the previous lecture, the benign ovarian mass, including ectopic pregnancy, hydrosalpinx, tubo-ovarian abscess, endometrioma, functional cyst, mature teratoma, leiomyoma, mucinous cystadenoma, and serous cystadenoma. This is the benign gynecologic lesion with palpable mass. What is the non-gynecologic benign lesion like appendiceal abscess or mucocele, bladder diverticulum, pelvic kidney, urethral diverticulum, diverticular abscess, paratubal cyst, nerve sheath tumor? While the malignant non-gynecologic lesion including gastrointestinal cancer, retroperitoneal sarcoma, and metastasis. The imaging for diagnosis of ovarian cancer, including first the transvaginal and abdominal ultrasonography, which can differentiate different types of ovarian mass, either benign or malignant, with criteria of malignancy like solid mass, like partially cystic or partially solid mass, surface papillae, and multilocular, bilateral, fixed, associated with ascites, associated with enlarged lymph nodes. So many abnormalities can differentiate the cancer from benign lesion. So also by Doppler you will find abnormal vascularity and increased blood flow in the mass with abnormal blood vessels. This is by the ultrasound. If you found suspicious of malignancy, then you can do chest, abdomen, and pelvis CT scan. MRI also can be helpful in assessing pelvic mass and differentiating benign from malignant, and positron emission tomography is not indicated for diagnosis actually, but for detection of metastasis. Also bone survey for detecting of metastasis in the bones. Lab investigation include complete blood count, blood chemistry like kidney function test, liver function test, calcium to assess the paraneoplastic syndrome, serum biomarkers, which is very important, and the most important one is CA125, which is elevated in more than 80% of epithelial ovarian cancer, but in only 50% of early stage epithelial ovarian cancer. So in advanced stage, the CA125 is elevated in about 80% or more, but in early stage at 50%. But you should know that sometimes CA125 can be found elevated in benign lesion like endometriosis, like pelvic inflammatory disease, like fibroid. So the specificity and the positive predictive value of CA125 are higher in postmenopausal women than in premenopausal women. Why? Because the higher pretest probability of cancer and the lower prevalence of the benign lesion after menopause. The second and the very important really tumor marker, which is the human epidermis protein 4, HE4, which is a glycoprotein expressed in about 1/3 of ovarian cancers that lacks CA125. So it can be elevated in 1/3 of ovarian cancer that lacks CA125. Okay. HE4 is used primarily to assess disease progression and monitor for recurrence. So, what if I used both of them, both tumor marker, human epidermis protein 4 and CA125? This will improve the sensitivity and specificity of 6-item symptom index to 83.8% and 98.5% respectively. These symptoms include bloating, increased abdominal size, difficulty eating or feeling full quickly, and pelvic or abdominal pain. So, if I use the HE4 with CA125 with these 6 symptoms, yes, the sensitivity and specificity will be increased in diagnosing ovarian cancer. Another tumor marker is carcinoembryonic antigen, may be elevated in mucinous tumor, inhibin A and B, and serum alpha fetoprotein elevated in 6-cord stromal tumor, beta HCG, alpha fetoprotein, and LDH, lactate dehydrogenase, elevated in germ cell tumor. So, as you see, each cell tumor has its tumor marker. Each type of the tumor has a tumor marker, and the commonest, if we wanted to do one tumor marker, we are going to do CA125, as I mentioned before. Why? Because it is produced by the epithelial tumor, which is the commonest malignant ovarian tumor. What about the risk of malignancy index? How to calculate it? By this equation, if we multiplied the ultrasound result in the menopausal state, multiplied by the menopausal state, and by the serum measure of CA125, and you are going to give a score for uterine results for the signs of malignancy, like multilocular cyst, solid areas, metastasis, ascites, and being bilateral. And we give 1 point for each of them as regard the ultrasound result. While the menopausal state is scored 1 for premenopause and 3 for postmenopause. While serum CA125 is measured by International Unit per Milli. Please look to this table to understand more. This is the U score, the ultrasound score. This is the metastasis, the menopausal score, sorry, the menopausal score, and this is the serum CA125. We multiply U by M by serum CA125. If the score, the ultrasound score is 0, no feature of malignancy on ultrasound, or it can take a score 1 if one feature of malignancy, as we mentioned before, or taking a score 3 if 2 or more features of malignancy on ultrasound. As regards the menopausal state, if the lady is premenopausal, will take score 1. If she is postmenopause, will take score 3. Measure the serum CA125 by International per Milli. Then let us see the results. If the results of risk of malignancy index score greater than 200, this patient at higher risk and should be referred to gynecologic oncologist and the staging CT advised. If risk of malignancy index between 25 to 200, this is intermediate risk, and MRI is recommended to further evaluate the lesion. If risk of malignancy index score less than 25, this is a low risk. So we are going to do repeat clinical assessment and repeat evaluation for the case. Okay, but we may need MRI also in such low risk patient if the ultrasound features are borderline. Another score for malignancy called ROMA score or ROMA score, Ovarian Malignancy Risk Algorithm. What about this score? The malignancy algorithm, ROMA, utilize a mathematical formula that incorporates human epidermis protein 4 and the CA125 level adjusted for pre- and post-menopausal state to determine the risk of malignancy. So, this score includes 3 items: human epidermis protein 4, CA125, and the degree of menopause, pre or post-menopause. ROMA is a valuable screening test that makes the advantage of the high specificity of human epidermis protein 4 and the high sensitivity of CA125 to detect more patients of ovarian cancer overall, especially in early stages. What is the reference value in the female? Human epidermis protein 4 should be less than 140 picomole per liter, while CA125 should be less than 46 units per liter. What is the score in premenopause and in postmenopause as regard ROMA score? The value of 1.14 or greater indicate higher risk of finding epithelial ovarian cancer in premenopause, while if it is less than 1.14, she is at lower risk of finding epithelial ovarian cancer. This is for premenopause. What about postmenopause? A score of 2.99 or greater indicating a higher risk of finding epithelial ovarian cancer, while a score below this number, 2.99, indicate lower risk of finding epithelial ovarian cancer at surgery in postmenopausal women. ROMA is indicated for women who meet the following criteria: older than age 18, non-pregnant, presenting with adnexal mass for which surgery is planned, and who have not yet been referred to an oncologist. ROMA must be interpreted in conjunction with clinical and radiological assessment. Of course, you should use all of them: the ROMA score with the clinical results and radiological evaluation. Endoscopy. Cystoscopy, yes, maybe need to exclude bladder metastasis, and the proctor sigmoidoscopy to exclude colonic metastasis or primary lesion. Biopsy and histopathology can be taken through CT guided biopsy or ultrasound guided biopsy, but there is risk of metastasis during taking this biopsy. Laparoscopy for staging and the biopsy. Laparotomy, actually the best optimal staging with exploratory laparotomy and close evaluation for the abdomen and the pelvis, looking for peritoneum in the pelvis and the abdomen, momentum, pelvic organs, undersurface of the diaphragm, liver, spleen, colon, for any implants or any metastasis can be detected, and do staging. What are the criteria suggesting malignancy on laparotomy? The solid mass, fixed, presence of ascites, bilateral tumor, large blood vessels on the surface, invasion of the capsule or extracystic papillae, positive para-aortic lymph node, and the presence of metastatic implants, presence of adhesions, all these, and the bilaterality, all these considered signs of malignancy. Genetic testing is something very important in cases of ovarian cancer, and the genetic counseling. Actually, in BRCA 1 and 2 and the Lynch syndrome, the 3 known autosomal dominant germline mutation importing a high risk of ovarian cancer, with lifetime risk of developing ovarian cancer 40%, 18%, and 12% respectively. And if we wanted to compare it with general population as in this table, please look to this. The lifetime risk of developing ovarian cancer in BRCA1 is 40%, while in BRCA2 is 18%, while Lynch syndrome 12%, while in the general population risk is 1.3%, while risk for women with a first degree relative is 4%. Women should be referred to genetic counseling. Yes. Which one you should ask for genetic testing? And what is the indication? First degree relative, aged less than 60 years at diagnosis. More than one first or second degree relative at any age on the same side of the family diagnosed with invasive epithelial, ovarian cancer. Strong family history of both breast and ovarian cancer. A family history of breast and or ovarian cancer with Ashkenazi Jewish heritage. If you remember, when we said in cases with BRCA mutation, the possibility of cancer in Jewish Ashkenazi, 1 in 40 or 1 in 50, so it's very hard. What is the method of spread? The commonest method and the earliest method of spread is the transcoelomic spread, which refer to the route of tumor metastasis across the body cavity, such as the peritoneal cavity. This is the commonest and the earliest one. Direct spread to the surrounding genital and extragenital organ, another way of spread. Lymphatic spread is the main route of spread in germ cell tumor. Lymphatic spread reach the para-aortic lymph nodes and pelvic lymph nodes, and can reach supraclavicular lymph nodes in advanced case. Hematogenous spread at the time of diagnosis is uncommon, and if it happens, it involves lung, liver, brain, and bone. Staging of ovarian cancer according to the 8th edition of American Joint Committee of Cancer, International Federation of Gynecology, the FIGO, staging system, and corresponding tumor node metastasis classification. But first, we should know this very well. If all primary tumors, malignant or potentially malignant, of the ovary and the fallopian tube and the primary peritoneal carcinoma are covered in this stage. So we are covering three items: ovary, fallopian tube, and the primary peritoneal carcinoma. These topics are not covered. What is the topics not covered? Metastatic tumor to the ovary and the fallopian tube, hematopoietic malignancies, peritoneal primaries other than primary peritoneal carcinoma, like mesothelioma, gastrointestinal stromal tumor. Stage 1. Stage 1A, tumor limited to one ovary, capsule intact, or fallopian tube, no tumor on ovarian or fallopian tube surface, no malignant cell in ascites or peritoneal wash. B, tumor limited to both ovaries or fallopian tube, no tumor on ovarian fallopian tube surface, no malignant cells in ascites or peritoneal wash. 1C, tumor limited to one or both ovaries or fallopian tube with any of the following. C is divided into three categories. C1, surgical spell. C2, capsule rupture before surgery. C3, malignant cell in ascites or peritoneal wash. Stage 2, extension and or implants on the uterus and or fallopian tubes and or ovaries. Extension and or implants on other pelvic tissue. Stage 3, 3A1, positive retroperitoneal lymph node only, histologically confirmed. And this can be divided into two groups. If the size is 10 millimeter in greatest dimension, it is the first group. If it is more than 10 millimeter, it is the second group. 3A2, microscopic extrapelvic peritoneal involvement with or without positive retroperitoneal lymph nodes. 3B, macroscopic peritoneal metastasis beyond the pelvis 2 cm or less in greatest dimension with or without metastasis to the retroperitoneal lymph node. 3C, macroscopic peritoneal metastasis beyond the pelvis more than 2 cm in greatest dimension with or without metastasis to the retroperitoneal lymph nodes. Include an extension of the tumor to the capsule of the liver, capsule, not the parenchyma. Be careful about this part. And the spleen, capsule also of the spleen, not the parenchyma. Stage 4, A, pleural effusion with positive cytology. B, liver or splenic parenchymal metastasis or metastasis to extra-abdominal organ like inguinal lymph nodes and the lymph nodes outside the abdominal cavity or transmural involvement of the intestine. This is staging in one slide. TNM staging, T for tumor, N for lymph node, M for metastasis. T we covered before in the previous staging. N, lymph nodes, as you see here, N0, 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 N1, any N till the end. Metastasis here, M0, M0, M1, M1A, M1B in stage 4. To understand the TNM staging, you should know about the lymph node. NX means regional lymph node cannot be assessed. N0, no regional lymph node metastasis. N0, I plus, isolated tumor cells and regional lymph nodes less than 0.2 millimeter. In 1A, lymph node metastasis deposit more than 0.2 millimeter to less than 10 millimeter. In 1B, lymph node metastasis deposit more than 10 millimeter. What about metastasis? M0, no distant metastasis. M1A, pleural effusion with positive cytology. M1B, liver or splenic parenchymal metastasis or metastasis to extra-abdominal organ, including inguinal lymph nodes and the lymph nodes outside the abdominal cavity and the transmural involvement of intestine. How to do screening? Actually, there is no effective screening for ovarian carcinoma till now. However, we can use different methods for ovarian screening for ovarian carcinoma, like C125 and ultrasound. Okay, this is the most studied ovarian cancer screening modalities. Here there is controversy between United States and the United Kingdom in their trials, their clinical trials. And while the United States found that using these tests to screen average risk women don't decrease mortality risk and was associated with increased harm. On the other side, United Kingdom trial reported the benefit of screening with no substantially increased harm. So it's a matter of controversy and should know that. And actually, why we can't find a very efficient method for screening of ovarian cancer? Because serous cancer or epithelial cancer is the commonest, and if we understand the theory that say this is coming from the fimbrial end of the fallopian tube and starting as intraepithelial serous carcinoma, so it can't release in the circulation any hormones or DNA which can be tested as a screening method. That's why we cannot diagnose the early stage of serous carcinoma. We should understand this point. Okay, based on result of the lung colorectal cancer ovarian screening trial and other studies in the United States Preventive Services Task Force and the American Academy of the Family Physician recommend against routine screening for ovarian cancer in asymptomatic women, but recommend that women with a high risk family history be offered referral for genetic counseling and, if appropriate, genetic testing. So they encourage the genetic testing as we mentioned before. How to prevent? As done by one of the famous actress, she did bilateral salpingo-oophorectomy because she has a positive BRCA gene mutation. So bilateral salpingo-oophorectomy is the most effective prophylactic treatment for BRCA carrier. It reduces ovarian cancer by 69% to 100%, but small risk of developing peritoneal carcinomatosis remain. Induces premature menopause with its attendant risk and limits reproductive capacity, and also negatively affect women's body image and sexuality. Of course, removal of the ovaries in young age has its risks, and it is dangerous also in the other sides and the other systems of the body. Then coming tubal ligation or hysterectomy associated with up to 30% of reduction of risk of developing ovarian cancer, avoiding postmenopausal hormone therapy greater than 5 years, and maintaining a healthy lifestyle would be preventing method for ovarian carcinoma. Long-term hormonal contraception, COC or Depo-Provera, is a promising comprehensive approach even for BRCA1 carrier and especially in women with early menarche, women who delay first pregnancy or women who are infertile. But on the other side, this potential benefit should be balanced against the adverse effect and the slight increase in the risk of the breast cancer. Of course, we know the link between this hormonal contraception, and the breast cancer. Avoiding postmenopausal hormone therapy, as we mentioned before. So, what is the treatment of ovarian cancer? The triage guidelines from the American College of Obstetricians and Gynecologists, Society of Gynecologic Oncologists recommend referral of women with pelvic mass at high risk of ovarian cancer to gynecologic oncologists. Why? Because the woman needs specialized treatment, and then we are in need for improving the patient's outcome and fewer complications and the better survival rate. And this can be achieved with gynecologic oncologists rather than surgery. Why? Because surgery is less familiar with the management of ovarian cancer. So this is as regard the guidelines. So what is the first line of treatment of ovarian carcinoma is surgery. Surgery, debulking, cytoreduction, and the removal as much as we can from the tumor. Actually, we are going to do bilateral salpingo-oophorectomy and hysterectomy and the infracolic and the infragastric omentectomy and the resection of any other visible disease and the dissection of the pelvic lymph nodes also and the para-aortic lymph nodes in early stages disease. While in late stage disease, we concentrate on the debulking surgery and the infracolic and the infragastric omentectomy and the resection of any other cross-visible disease, but not the lymph nodes, because there is clinical trial found, the Lion phase 3 trial published in 2019, found that in patients with stage 3 or 4, lack of benefit for routine lymphadenectomy. So it is not advised for late stage disease of ovarian carcinoma to do lymphadenectomy, but as regard the early stage 1 or 2, we can do resection and the lymphadenectomy during surgery. Of course, during surgery, we are doing staging, we are doing peritoneal wash, we are inspecting and send for cytological analysis, and if there is ascites, we take sample and send for cytological analysis for searching for any malignant cell. We inspect the pelvis, abdomen, omentum, peritoneum, and organs, and under surface of the diaphragm, liver, and spleen. We are inspecting and palpate the pelvic and the para-aortic lymph nodes. So you are doing staging laboratory. Okay. Can I do fertility sparing surgery? Yes, I can do it by removing unilateral, by doing unilateral salpingo-oophorectomy, preserving the uterus and the contralateral ovary, and this can be done in early stage invasive epithelial ovarian cancer in young women, lesion with low potential for malignancy, lesions with histologically abnormal cells that are judged to have low likelihood of developing into cancer. Also, a germ cell tumor and sex-core stromal tumors. Then you are going after surgery to give the patient chemotherapy, and this is called adjuvant chemotherapy. And this chemotherapy doesn't preclude fertility, okay? And is recommended for stage 2 and the late stage disease cases, but generally not indicated when the disease is confined to the ovary. We need 6 cycles of chemotherapy with carboplatin, paclitaxel, given 3 times weekly. The available evidence support the use of adjuvant chemotherapy in patients with early-stage ovarian cancer with high-risk features like stage 1C and the stage 2 disease and the clear cell or high-grade histology. So, another line of treatment is intraperitoneal and intravenous chemotherapy. This therapy increases the median survival rate by 12 months compared with intravenous chemotherapy alone, and is the current standard of care for late-stage tumor. This is an example of different chemotherapy. Another line of treatment is called neoadjuvant chemotherapy. Neoadjuvant means you give chemotherapy pre-surgical, before you do surgery. Why? Because you are trying to make the surgery less radical, and the patient will be in a better physiological state with reduced tumor burden and ascites after 3 cycles of chemotherapy. So it can be helpful for the gynecologist to give 3 cycles of chemotherapy, then do surgery or debulking surgery, okay, after that. But neoadjuvant chemotherapy has been shown to have equivalent survival with reduced morbidity. So, in neoadjuvant chemotherapy, we will put the plan for the patient if we expecting from the imaging technique that this is an advanced stage of ovarian carcinoma and the operation will be difficult. We can do the neoadjuvant chemotherapy by giving 3 cycles of chemotherapy before surgery, then do debulking surgery, then continue with another 3 cycle chemotherapy post-operative. Another line of treatment is the intraperitoneal chemotherapy. As you see in the picture, we pump the chemotherapy inside the peritoneal cavity through caster, through incision in the abdomen, and insert the caster, and this chemotherapy pumped inside. Some patients with advanced epithelial cancer and the peritoneal cancer with low volume residual disease after debulking surgery are eligible for intraperitoneal therapy. It has shown promise in recent years by improving patient survival rate. In this therapy, a small incision is made in the abdominal wall and the caster is inserted through the subcutaneous tissue where it is inserted into the peritoneal cavity, as we mentioned before. Treatment with hyperthermic intraperitoneal chemotherapy for women with primary ovarian cancer has recently been grown interest, like this picture. Hyperthermic intraperitoneal chemotherapy has been implemented in other peritoneal malignancies and was successful as in epithelial and gastric cancer, was associated with an improved recurrence-free survival and overall survival when compared with the standard treatment or with comparable complication rates. Another line of treatment, which is treatment with poly-ADP ribose polymerase inhibitor or PARP inhibitors. This can be used as a maintenance therapy after completion of primary adjuvant therapy in patients whose tumor had a good response to chemotherapy. So you should have a good response to chemotherapy to give PARP inhibitor. These PARP inhibitors stop the process of regeneration in cancer cells, prohibiting gross and larger tumor formation. Niraparib had FDA approval in April 2020 for the use as a maintenance therapy in women with advanced epithelial ovarian cancer who have had a complete or partial response to the primary platinum-based chemotherapy. Another line of treatment is the use of anti-angiogenic therapy. Actually, bevacizumab, approved by FDA in 2018 as a frontline treatment in stage 3 and 4 ovarian cancer. However, in 2019, the updated results showed that there was no overall survival benefit with concurrent and maintenance bevacizumab added to standard chemotherapy. So, what is the end result of this controversy? It is advised to reserve frontline bevacizumab use for patients who have had suboptimal tumor debulking and in patients with stage 4 disease, or those who have had poor response or refractory to frontline carboplatin or paclitaxel chemotherapy. Lastly, treatment with immunotherapy, the novel therapy really, include immunotherapy with monoclonal antibodies such as nivolumab. What about the role of radiotherapy? Actually, radiotherapy has a very limited role in ovarian carcinoma, but its main value coming in as a palliative treatment, especially in localized growth of the tumor, which causing problem. So, if I have localized spread of the disease, okay, and I wanted to do symptom control, I can use radiotherapy, especially the new one, the stereostatic body radiotherapy, like in the picture. And this is a new technique for palliative radiation. High rate, but there is still high rate of distant progression of the lesion with its use, even when local control is achieved. So I cannot control the distant metastasis, but I can only control the local growth to control symptoms, and they can be used as a palliative treatment. What about the post-treatment care? Of course, this patient need emotional support and the monitoring for and managing treatment complication and comorbid conditions and promoting general well-being. Also refer to genetic counseling if not done before. Approximately 25% of patients diagnosed with early stage disease and 75% to 80% of patients with advanced disease experience recurrence within 5 years. However, evidence on the effectiveness of post-treatment surveillance for preventing or minimizing disease-related outcome is limited. Post-treatment surveillance should be provided by the gynecologist oncologist for the first 5 years after diagnosis. The recommended surveillance testing for epithelial ovarian cancer varies according to the histologic type. CT, BET, or both are recommended for recurrence if suspected. Measurement of CA125 and human epidermis protein 4 levels is recommended if they were elevated at the time of the diagnosis, and also measurement of inhibin A and B is used in post-operative follow-up for 6-core stromal tumor. So please look to this slide to understand how is the surveillance and what is the recommendation for epithelial ovarian cancer. We will ask the woman to come every 2 to 4 months for 2 years, and then every 3 to 6 months for 3 years, then every year for 5 years. Okay, this is the visits. In each time, you should do physical examination, abdominal and pelvic, and of course general examination. And after pelvic examination, you should do ultrasound examination. It's very important. Then test for C125 and other tumor markers every visit if initially elevated. So should be initially elevated to do follow-up by this tumor marker. Genetic counseling referral if not done before. CBC and the blood chemistry as indicated. You may need chest, abdominal and pelvic CT scan or MRI or PET CT or PET positron emission tomography as clinically indicated. It depends. And each case is specific for what is needed for this imaging. Chest radiography as clinically also indicated. What is the treatment if recurrence happens? If recurrence of ovarian cancer happens, the treatment could be surgery by secondary debulking for recurrent ovarian cancer with platinum-sensitive disease who had relatively long tumor-free interval, at least should have a free interval of 6 or 12 months after completion of chemotherapy. And also she should have isolated lesion or small volume disease and minimal ascites to do surgery. Okay? The American Society of Clinical Oncology 2020, in their annual meeting, demonstrated an improvement in post-progression free and overall survival. However, the results also demonstrated that in patients who had an incomplete resection of their tumor, those who had surgery had shorter overall survival than those who didn't have surgery. And you should understand this point very well. Okay, what about the systemic therapy in cases with recurrent ovarian cancer? Most patients with recurrent ovarian cancer are treated with cytotoxic chemotherapy during the course of their disease. The current standard of care for the first line treatment of platinum-sensitive recurrent ovarian cancer is carboplatin-containing combination. Frequently, I can use also liposomal, doxorubicin, gemcitabine, or taxane. Several studies have demonstrated approximately 4 months improvement in progression-free survival with addition of bevacizumab. What about the PARP inhibitor, polymerase inhibitor? In combination with other agents are also being evaluated in the recurrent treatment setting. On the other side, immunotherapy has proved effective in a number of recurrent cancer, but has been less successful for patients with ovarian cancer. So the result up to now in ovarian cancer is not promising. What about the palliative and the end-of-life care? We should focus on maximizing quality of life through aggressive management of distressing symptoms like pain, respiratory symptoms, nausea, vomiting, urinary tract infection, renal failure, edema, cancer-related fatigue, neuropathy, hypercalcemia, anxiety, or depression. Chemotherapy is occasionally used for palliative treatment for relieving of symptoms. Ascites should be managed with acetic tabs, and also you can insert catheter or drain to avoid multiple paracentesis. There are rare situation in which targeted radiotherapy for symptom control is used if solid mass are causing compressive or obstructive symptoms. The terminal phase in the care continuum, validated tools such as memorial symptom assessment scale facilitate communication between the patient and the care team. Also, don't forget the psychological and social support for patients and the family, as well as spiritual and existential issues. Comfort care is critical when death is imminent. Complication in late stage disease, ovarian cancer, including nausea, vomiting, fatigue, weakness, constipation, disorder of nutrition and cachexia, bedal edema, anemia and ascites, pleural effusion, bladder obstruction and intestinal obstruction. What is the prognosis? Of course, the prognosis depends on the stage of the disease, the type of the disease and its histological type and the immunohistochemistry and the molecular characteristics, the baseline performance status, and the volume of residual disease post-primary cytoreductive surgery. And this is very important. The first operation is the first important item in the prognosis, is to be optimum cytoreduction, remove all the tumor, all visible tumor. Don't leave behind you any centimeter. They are saying that the optimum, if you remove all or leave behind you less than 1 centimeter. But really, the optimum is not to leave any lesion behind you. And this improves the prognosis, really. Okay? The median survival of ovarian cancer is approximately around 40 to 50% at 10 years. But if we look according to this stage, the stage 1 between 70 to 92% compared to stage 4, which is less than 6%. As regard recurrent platinum sensitive ovarian cancer, median survival is approximately 3 years, while it is about 1 year for platinum resistant patients. Lastly, thank you.